So we talked about the infusion-related reactions, the time of infusion, the volume, the management of all of these things, the concentration. So a lot of factors to consider, but a good segue into giving DARA subcutaneous. We know that, for example, rituximab was recently approved to be given subcutaneously. IVIG, which is commonly used, can be given subcutaneously. And of course, the question is, what about DARA? So DARA can be given subcutaneously, but one of the limitations of giving antibodies, if you just give it, the volume of the antibody would not necessarily diffuse through the subcutaneous compartment. So in order to give DARA subcutaneously, it's mixed with hyaluronidase. And so what this does is it allows the drug to be given subcutaneously in a relatively small volume of 15 mL, and it can be given in the abdominal site. So the important study that led to this, the phase 3 study that compared subcutaneous and IV DARA is called the COLUMBA study, and that was recently published in Lancet by Mari V. Mateos. The eligibility criteria were patients with at least 3 lines of prior therapy, including a PI and an IMiD, or they had to be refractory to PI and an IMiD. And the patients were stratified by 3 different criteria: body weight being less than or greater than 85 kilo, less than or greater than 4 lines of therapy, and IgG versus non-IgG subtype. So the randomization was 1-to-1, and about 260 patients got daratumumab subcutaneous. Importantly, this is a flat dose, 1,800 milligrams, and it was given subcutaneously, as I mentioned, in 15 mL. And it was given at the same schedule that Danny just outlined for IV. And the comparator group was standard DARA IV at the standard dose and schedule, 16 milligrams per kilo. There were 2 primary endpoints, or co-primary endpoints. One was the response rate, and the second one is the maximum C trough. C trough is basically the dose, the concentration of DARA after you finish those 8 weekly doses. At cycle 3, day 1, if you will, because that C trough level has been correlated to efficacy in other studies. So in this study, obviously one of the most important and interesting findings is that the median duration of infusion in the first administration was 421 minutes for the IV versus 5 minutes for the subQ. And that goes to 255 minutes and 5 minutes for the second dose, and 205 minutes, and remains, of course, 5 minutes. So we're looking at 7, 4, and a little over 3 hours for the IV, whereas the subQ remained flat at this 5 minutes. So that primary endpoint was response rate with a median follow-up of 7.46 months. Response rate of subQ, 41% versus 37%. VGPR and better, 19 versus 17%, so looking comparable or non-inferior. The co-primary endpoint, C trough, was also very comparable, the 107.93%. So C trough, if anything, was slightly higher with DARA subQ than IV. But really, again, this was non-inferior, and that criteria was met. When we looked at the patient, their cancer treatment satisfaction, it continually improved with DARA subQ. Who wants to spend more time in an infusion center? And importantly, I think one of the things that we've been talking about with the IV DARA is the infusion-related reactions. So when we look at the so-called IRRs, subQ DARA, the rate was only 13% compared to 34% for IV. And most of these infusions occurred during that first dose, as we would expect even with IV. Grade 3 was very uncommon, 2% versus 5%. There were no grade 4 or 5. And the infusion-related reactions were what you would expect in IV as well. Chills, 5% versus 12%. Pyrexia, 5 and 3%. Dyspnea, 1% versus 7%. One difference is the median time to infusion-related reaction. So with DARA, the subQ was 3.4 hours. Again, the drug is being diffused slowly, versus intravenous was 1.5 hours. So I think that was an important study to show the benefits of intravenous versus subcutaneous DARA. The primary endpoint response rate was comparable, C trough comparable. So we have basically comparable efficacy with what appears to be an improved safety profile with lower rates of infusion-related reaction, obviously way more convenient. And then finally, the rates of infusion-related reactions were lower. Moving to the other study, which is important because this was a single agent non-inferiority study. This was a phase 3. There's also the PLEIADES study, which I've updated at ASH. And basically, this is a slightly different study because it's DARA in combination with some of our standard backbones that we covered. So DARA in combination with VRD, as was done in the Griffin study. So this is subcutaneous DARA. DARA in combination with VMP, as was done in Alcyon with subQ. and finally in DRD as per Maya, but again, the subQ dara. So subQ dara given with the backbones. The primary endpoints were different for these three arms. The primary response for the DVRD was VGPR and better, because this was only 4 cycles of administration, whereas the DVMP and DRD were overall response rate. And there were some key secondary endpoints. But each group had about 67 patients in each arm, kind of what you would expect for the patient populations. The response rate for DVRD was 97%, 89.6% for DVMP, and finally 94% for DRD. So kind of comparable to what you would expect for the intravenous regimens. Importantly, the rates of infusion-related reactions were very low, 9% for DVRD and DVMP, and only 4.6% for DRD. So really very low rates, very easy to administer. And again, most of these occurred in that first dose, very little in subsequent doses.